So you're all really, really welcome. For those that don't know me, as Sue very kindly introduced me, I'm also the Active Iron Pregnancy Advisor, and it's under that guise that I'm speaking with you guys today. So what I'm going to be talking about, well, obviously iron, and the fact that it's a vital nutrient, deficiency is a progressive journey, the current guidelines, why does oral iron fail, why does it so commonly fail, and what are some of the things that we can do to help women avoid this. And then I'm going to be introducing some Active Iron new clinical data that is nearly about to be published from an Irish perspective and a UK perspective, which showed some really, really interesting things. So as we all know from our anatomy and physiology, and I see one of my old lecturers here today, so I should know it for sure, it's essential for oxygen transportation, energy metabolism, cognitive function, blood cell formation and cell division, contributes to a healthy immune system, which we all know is so important, particularly in these post-COVID-19 or during COVID-19 times. And very interestingly, unlike a lot of other micronutrient deficiencies, it affects low, middle and high income countries. And I suppose sometimes we think of nutritional deficiencies in terms of the countries that people might come from, or in terms of different parts of the world, but this very much affects unilaterally the entire planet. To such an extent that approximately 2.1 billion women and children around the world suffer from an iron deficiency of some number. And 1 in 4 women are estimated to have low iron. And that's not in pregnancy, that is in the general childbearing populace, which is an unbelievable amount, really, when you consider the amount of women that become pregnant, and then if they're entering into that pregnancy already on that road of deficiency. We know that in the general population outside of being pregnant, that women need about 2 times the amount of iron that men do, due to many different factors, not least of menstruation. But inside of pregnancy, we know that the amount that's required doubles, if not triples. And we know that the prevalence of deficiency, there are certain groups that are more at risk. In recent survey that we undertook with 2,400 women across the UK and Ireland, 67% of women said that they experience a heavy period. And we know that 10 to 20% of menstruating women are already deficient, that's preconception. And really importantly, and I try and hammer this point home as strongly as I can, once a pregnant woman is deficient, diet alone, no matter how much iron that they can try and ingest, which can be quite challenging in their diet, will never be enough to replenish their levels. So deficiency is progressive, it's a sliding scale. When somebody ends up being deficient, it has taken a long road for them to get there. And you've your normal, you've your storage iron, which is your ferritin, and your functional and transport iron in your actual hemoglobin in the blood. Then you're iron depleted, so it's only affected a portion of your storage iron, but it's getting there. But if you did your hemoglobin, it would actually appear to be totally normal. And I suppose this is one of the issues in that in lots of clinics, we don't routinely check ferritin levels. So while somebody might present at having a perfectly okay hemoglobin, they might already be on the road of progressive deficiency. And then you've iron deficiency without anemia, so they might be on the slightly low end, but their ferritin stores are totally depleted. And then finally, iron deficiency anemia, which is at the very end of that long road. So how can we get in there before that becomes an actual issue and is a lot more difficult and challenging to treat, not least for the women themselves? So as I mentioned, there's a 2 to 3-fold increase in iron requirements during pregnancy and the postnatal period. We know that when you have a healthy mother, you have a healthy infant. All of the research and data tells us so. So ensuring that mothers themselves have an adequate iron level is doing something for their children, but also for their future health, well-being, and future pregnancies. The Centre for Disease Control in the States recommend 27 milligrams. WHO recommend between 30 and 60 milligrams. And in Ireland, we recommend around the 27 to 30 milligrams. So the current guidelines, anemia is defined, as we know, as less than 11 in the first trimester, less than 10.5 in the second, less than 10 in the postnatal period. What isn't taken into consideration in any of these are an actual woman's physical makeup. We've all seen women who might appear to have a normal hemoglobin or slightly on the low side, but they can be incredibly symptomatic. It doesn't take into account really the variety of different makeups or how specific birth blood loss, where somebody might lose 300 mils and be absolutely fine. Somebody else who is of a small stature might lose the exact same amount and might be really symptomatic. And we can put a lot of that down to, well, you've just given birth, you're just tired. Unless somebody is really symptomatic, we don't routinely check their hemoglobin. So therefore, to try and get in there before things become a problem, I would argue is a very good idea. The FBC at booking and at 28 weeks and seroferritin should be checked in women who, although not anemic, are at increased risks of deficiency, but that's totally up for different clinics to decide. And I sometimes ask, and don't always get the answers, why we don't check ferritin more readily. And I know that there are studies ongoing in some of the trusts in the UK where during COVID in particular, they started checking ferritin, and some of the results of that were that they were really able to identify people long before they got to a stage where it was a far more difficult deficiency to treat. So risk and effects on mother and baby. Depletion of iron stores and ferritin levels, impaired hemoglobin production, anemia in pregnancy, increased susceptibility and severity of infections, poor cognition and low productivity. So tiredness, feeling, the things that we put down to normal symptoms of pregnancy when in fact you might actually have a low iron level, increased risk of maternal mortality and morbidity, increased risk of PPH, which is very interesting because obviously if you've already got a low hemoglobin and then you have a bleed, you're going to be affected really, and impacted by that. Fatigue, shortness of breath, palpitations, and very interestingly, lots of more recent work has been done on looking at the connection of low iron between depression, low mood, and irritability. So on the baby, obviously, if you have a mother who's affected by iron, you're going to have the baby might be affected. They have well-recognized lower birth weights, higher incidence of preterm birth, higher incidence of congenital abnormalities, a huge increase in cognitive impairment, and that's going up until those babies are tested at the age of 5 or 6. So it really is long-term, and then increased risk of perinatal mortality and morbidity. So traditional oral iron supplements and treatment failure. Why is it so challenging? Firstly, it's poorly absorbed. Secondly, there are huge gastrointestinal side effects. If anybody has taken a standard iron ferrous sulfate, it isn't very pleasant. And when you are already pregnant, the reason that we have a huge amount, so about 50% of women that are prescribed ordinary ferrous sulfate will actually stop taking it because the side effects, the cure is far worse than the illness itself. And that's a huge amount. If you take that, the amount of women that are already perhaps deficient in iron, and we try and treat those and 50% of them aren't going to take that, that's very, very worrying. And we know that it has enormous health implications for mum and baby. We know then if you wait until the 3rd trimester or postnatally to try and actually treat the deficiency, you have to give really, really high oral doses. The higher the dose, the higher the side effects. And then if the oral iron fails, you have IV iron treatment, which if anybody has undergone it themselves or certainly have treated women, is very uncomfortable, is very time consuming, and is also very expensive. So uncomfortable, costly, and challenging for mum and healthcare provider, never mentioning if you actually need a blood transfusion, all of the extra sequelae from that. So what I would argue is that preventative supplementation is key, and that could be considered from preconception to fourth trimester to try and catch all of the women that might be susceptible to it. I would argue that prevention is always better than cure, and that we as midwives have a huge role in health optimization. So many women have low iron stores pre-pregnancy, and by the time they are identified, it's much more difficult to fix. I would argue that preventative iron supplementation and early intervention to encourage maintenance of iron levels throughout the pregnancy, better nutritional information advice, would preclude much more expensive, risky, and uncomfortable treatments for the women themselves. And we know, as I've mentioned before, healthier mums and healthier babies equals healthier pregnancies. That means better birth outcomes for all service users, not least of the midwives and healthcare professionals looking after them. So what did the new clinical data and what did the study look at? So firstly, there was a screening study with 204 women. It was to investigate the prevalence of inadequate iron levels in a screening cohort study of women of childbearing age with a self-reported history of intolerance of oral iron. So this was Irish women themselves that had a reported history of iron intolerance, so they hadn't had good iron experiences. Of that, there was a treatment study with 59 women. What did we look at? We looked at compliance levels, gastrointestinal tolerability, and efficacy, and associated with 3 different doses of active iron in a difficult to treat cohort. So the screening results, almost 2/3 had inadequate iron levels, which wasn't particularly surprising. The most common adverse gastrointestinal side effect were, as we know, constipation, and that affected 8 out of 10 of the women. And abdominal pain and nausea affected nearly 60%. So what did the screening study results reveal? Firstly, there were 4 times better compliance. So when women took specifically active iron, they were able to tolerate it far better and stayed on it for longer, and obviously then got the benefits of it. They had significantly improved gut symptom score on active iron versus previous oral iron. So as you can see from that table, at baseline, it was low at active iron at 6 weeks, and active iron at 12 weeks it maintained. And that was very interesting because it showed that even taking it over a long period of time, the gastrointestinal effects didn't multiply. What was also interesting was one of the study groups was on 25 milligrams, the other was on 50 milligrams, and they were pretty much equidistant with regards to how comfortable it is. So it meant that having to double dose, having to take 2 capsules, didn't increase your risk of gastrointestinal side effects. 6 times less gut irritation on active iron versus previous oral iron, which was what we hoped, but it was even better than expected. And really importantly, it showed a 94% increase in the iron stores of ferritin levels over a 6-week period, and that was maintained at 12 weeks, which was even far better than we had have actually previously thought. So it was really, really interesting, and now shows that we can clinically and definitively say that active iron itself increases iron stores. Increases in hemoglobin in a patient with anemia, so the mean levels increased, and again that increase, so the people that were particularly deficient showed the even better results, which was really, really brilliant. And very importantly for pregnant women and new mums, energy and fatigue scores improved considerably as well. So on everything that we looked at, it was quite startling in just how good it was within a kind of a clinical setting. So active iron is kind and strong, 4 times better compliance, 6 times less gut irritation, 94% increase in median iron stores. So up from a baseline, for example, from 8 up to 15 international units per litre. The overall group taking active iron, so that was a mix between the 25 milligram and the 50 milligram, and the energy scores increased. So good for women. So the complete nutritional supplement. So we don't only just do iron. There is Pregnancy Plus, which has active iron. It has a sustainably sourced omega-3, and it has a multivitamin containing active folic, which is also better absorbed. If you haven't already, please come and feel free to pepper me with questions at the stand, and we'd be delighted to give you a full-size sample, and also that you can request a free 20 amount of 5 capsule sample packs for the women in the clinic or in the community in where you work. We can give you a little card and you just scan, and you can try it for yourself and see what your own women and the women in your care or yourselves think of it. So in conclusion, inadequate iron levels have far-reaching consequences for mum, baby, and the wider global community. We as midwives and healthcare workers have a key role in health optimization education, providing holistic women-centered care and helping women to avoid treatment failure. What I would recommend and argue for is that routine supplementation for preconception to the postnatal period means that women at risk of developing inadequate iron levels, it precludes them from this. And the new clinical data that I've presented on active iron shows that it's proven to increase iron levels whilst avoiding the negative gastrointestinal side effects. Pregnancy Plus is a game-changing supplement and offers a complete nutritional solution for mum and baby, and is also Irish made. And please come to the stand yourself and you can try them all out. Any questions?